and it's my pleasure. I feel like David's an old friend. It's the third year that Dr. Jobes is presenting, and interestingly enough, each year
And you can
he's
even get her
presented
Chardonnay.
a different and important topic. Dr. Jobes is professor of psychology and director of the Suicide Prevention Laboratory at the Catholic University of America. He's past president of the American Association of Suicidology and has mentored dozens of students in suicidology over 3 decades. He's the creator and developer of the prominent CAMS, the Collaborative Assessment and Management of Suicidology, a suicide-focused clinical intervention. And I'm so glad that he took on the challenge of talking about the management of chronic suicidality, which is a vexing problem for all of us who work with suicidal patients. David?
Thank you, Doug. And thank you, Alan, also for organizing this conference once again, having me be on board. I'm really honored to be involved with this and delighted to talk about this topic. When Dr. Jacobs approached me about the prospect of talking about chronic suicidal risk, I thought, gosh, that's really not something I routinely talk about. And then I started thinking about it, and it's like, actually, I know a lot about it. Or I know my version about it, which I'm happy to share with you all today. These are my disclosures. I also contextualizes a bit of where I'm coming from. I've got funding from multiple agencies. I write books, and I'm in the training business. So that is part of what I bring to this is sort of an eye to training and how we get clinicians in the standard of care in general up to speed. I feel really well set up by Dr. Book and Donna for these two previous presentations. They really set up a lot of the things that I'll have to say in this course of this presentation. And when I talk about the DoD or the VA, I'm talking on my own behalf and not on behalf of the government. So if you are familiar with the field of suicide prevention, I've been at this for about 40 plus years since graduate school. The field has really been preoccupied for decades in the pursuit of typologies. And so when we talk about chronic suicidal risk, I want to really remove any sort of stigma or pejorative nature to it. This is meant to be descriptive. It's meant to understand the psychology of people who've been suicidal, sometimes for decades or many, many years. And so in that descriptive sense, we've been pursuing typologies for example, acute versus chronic states in my lab for a number of years. This is a factor analysis that was done with an inpatient sample at the Mayo Clinic. And why this is important is that it helps us understand treatments. And the responses that you might have for somebody who's acutely suicidal versus someone who has more of a chronic profile can be distinctly different. So, for example, this construct of hopelessness, when we study hopelessness in college students, it's much more plastic and changeable when you're 18, 19, 22 than it is when you're a 35 or 38-year-old on an inpatient unit. And if you just think about the acute state of being hopeless, experienced over many, many years, moves from being like a static risk factor to more of a chronic state and more of a way of living and sort of a chronic state of hopelessness. So a lot of these constructs evolve and sort of become rooted over time. So these are various people in our field that are looking at different typologies. Emil Durkheim, who's one of the founders of the field in sociological perspective, some of the more technology-based approaches, the pursuit of a new DSM diagnosis. As a clinician, I can't get reimbursed for treating for suicidal risk unless it gives a patient a diagnosis that has maybe suicide implicated. We really need a diagnosis that's specific to suicide. So I've been at this for a while, as I've suggested. And one of the things that I would say in the research that I've done is we've studied clinical populations. This is a study going way back 28 some odd years, where we're looking at a counseling center sample. And the group that I'm focused on here today is the 21% of the students in this sample that remain chronically suicidal. Now, interesting about this sample was they did get better over the course of the year. The thing that didn't change was their attachment to suicide. And I say attachment as if it's a relationship. And for some patients, they do describe suicide as a kind of relationship. So it's interesting. They can do and get better on overall symptom distress, but still retain an attachment or a connection to suicide. Another kind of deeper dive that we took about 15 years ago at the Mayo Clinic was looking at a sample of inpatients and the idea that we have evidence that there's chronicity and acuity, and I'd done some work in that area early on, and that we wanted to sort of think about, what are different about these states and what's good or even problematic about hospitalization. And this is back in 2008, but a lot of these constructs and issues still are relevant today. So acute suicidal risk occurs in extreme of extreme overwhelm and high stress, and tremendous dysregulation, loss of prefrontal cortical control, think limbic activation, and a lot of that then is rooted in a kind of impulsivity. And from a suicidal ideation perspective, suicide can be like a hot potato, something that you want to get rid of, that's burning your hands, that brings no comfort, but you don't know where to throw it. A more chronic kind of suicidal risk is a more frequent, enduring consideration in the context of persistent distress over many years, perhaps. And you can think of some of the terms of like ego-dystonic suicide, that would be a acute state, or ego-syntonic suicide, means that suicide is something that's known, it's familiar to me. It's kind of like a warm blanket, if you will. It's something that actually brings me comfort and is something, it's like an old friend. Again, I'm saying this descriptively, not pejoratively, but for people for whom this is true, it really feels like I don't want to give this up because it's something I know. It gives me a sense of control, and I'm loath to give it up very quickly. And just a clinician saying, "Can you not be suicidal?" is insufficient to have me give up something that's become known and true in my experience. So we were operationalizing this, not kind of knowing what we would necessarily find. We had a large sample of inpatients. We went to the literature and looked at what might be sort of three criteria for operationalizing chronicity: 2 or more attempts, more long-term personality disorders, think cluster B in the previous DSM-4, and then multiple psychiatric hospitalizations was one way we were going to operationalize this. And we then were asking the question, which was being asked a lot then and still today, is someone for whom they're chronically suicidal, is being in the hospital a good thing, or actually iatrogenic or problematic? Marsha Linehan in particular, that Michelle was probably alluding to in her talk, Matthew Large in Australia, have talked about nosocomial suicides, which are suicides that he argues are caused by an inpatient hospitalization. So there are those of us who see hospitalization as the absolute last ditch response versus the first response. And there's a range of practices and ways that people think about this. But the real question is, if I'm interviewing a woman at the Mayo Clinic who's been hospitalized 28 times in 2 years, you start to wonder, are these hospitalizations actually helpful? And that's an actual person I interviewed a number of years ago. Is the time and attention from staff behaviorally reinforcing, therefore not helpful to that population? So we did this study, operationalizing acute versus chronic. We had 1,000 consecutive admissions from 2007, 2008. And the data were, I think, quite interesting, surprising, and actually illustrative of the points I want to make with you today. First up, and Michelle alluded to this, there were profound gender differences. So using the operational criteria I described, you multiple hospitalizations, multiple attempts, multiple or access to or cluster B personality disorders. 90% of our chronic group, that was 40 patients, were made up of women, and only 10% were made up of male patients. So very robust gender differences. Dr. Burke spoke to this. We have had gender differences throughout the history of suicide prevention. Men die by suicide. Almost 80% of our completed suicides are men. And the majority of our attempters are women. So we don't understand this. We don't necessarily know what that's about. But it certainly sort of broke down this group in very distinctive ways. Major depression was the primary diagnosis, along with other comorbid disorders. Now, this is interesting. When you look at acute males and acute females and chronic males, there's not a lot of differences in their ratings for a wish to live, or rating for wish to live from 1 to 9. But when we look at the more chronic state, there is a big difference among the women where they have a much higher rating of a wish to die in comparison to the acute males, acute females, and chronic males. So this speaks to a fundamental psychology of a chronic presenter, at least in the sample, where there's a relatively lower wish to die, significantly lower wish to die, and a significantly higher expressed wish to live. But this is interesting, that when you look at the males and the females in terms of their respective wish to die, both at admission and at discharge, and these are fairly short, brief stays, probably about 6 or 8 days, you see dramatic differences. But look at this. The men at discharge are or at admission and discharge are at the same level of wish to live in the chronic group. Whereas for the female patients, the rated wish to die is much higher at admission and comes down rather rapidly over the course of care. So it is a different kind of way of thinking about suicide. It seems to be a little bit more plastic in this scenario, but it's overall higher in this population as well. Now, as Dr. Burke spoke to, the king of working with chronic suicidal risk is dialectical behavior therapy. I am not going to begin to describe DBT as Dr. Burke was able to. I will just say that it's got dozens of RCTs in support of it, randomized controlled trials, and is by far the best treatment. And a very strong admonition from MARSHA and DBT clinicians is to try to keep a patient out of the hospital, unless with some exceptions for acute psychosis. Mentalization-based therapy out of the UK, developed by Bateman and Fonagy, is also another effective treatment. They have nice replicated data with chronic populations. If you're not familiar with mentalization, mentalization is looking at oneself from the outside and looking at others from the inside, and is very much wrapped up in attachment theory. It's a very nice model. They've got nice replication of RCT data, mostly on behavioral outcomes. There need to be independent replications. If I'd be remiss if I didn't say a little bit about my own intervention, the CAMS intervention that Doug alluded to. Our focus is on empathy, collaboration, honesty, and we're a suicide-focused framework. We target and treat what the patient says makes them want to consider suicide, which we call drivers. Within CAMS, we have a side-by-side seating arrangement. We have an assessment tool that's done collaboratively. The patient completes the first page. The clinician takes on over, talks about risk and warning signs, develop a suicide-focused plan designed to keep somebody out of the hospital. But to do that, we have to have a rock-solid stabilization plan, and we identify the 2 problems that make them suicidal. And as per Donna's commentary, this additional page of documentation, really you have extensive documentation for that first session. That's mostly done with the patient involved. Patients always get a copy of their SSF, and this kind of documentation is really quite important in terms of reducing risk of liability. There's a different version of the SSF for interim care, all those sessions after the first session, and outcome disposition, a way of sort of denoting when the intervention comes to a conclusion. So what you probably can't quite see here are the problems defined by the patient, in this case, self-hatred and interpersonal betrayal, for which we have many interventions to treat those kinds of problems. With COVID, we've now had to flip to being able to do this online. So it's a fillable PDF, and we've negotiated with the publisher having this now be a default resource in the menus of the big EMRs throughout the country and around the world. This is a lot of research, open clinical trials for CAMS. These are 10 published trials, all really looking at CAMS as a randomized control trial, which is the causal kind of impact. We're now 7 of these published trials. This is a meta-analysis of 9 trials. So meta-analysis is a study of studies. All the square boxes speak to significant findings. So CAMS is pretty much the best intervention for reducing suicidal ideation, overall symptom distress, and the single biggest effect size was for increasing hope and decreasing hopelessness. A head-to-head study between CAMS and DBT was conducted in Denmark in the mid-2000s by Marte Nordentoft and Kate Andreasen. CAMS did remarkably well, better than we ever would have expected, because DBT's really sort of the sweet spot intervention for this population of mostly patients with borderline personality disorder diagnoses or features and attempt histories. But CAMS fared quite well. So one of the questions here, which perhaps Michelle spoke to, is that we always wonder in these studies, is adherence to the model appropriate and fidelity strong? And there might be some questions in this trial, but good company to be in terms of decreasing self-harm and attempt behaviors. And interestingly, within the CAMS arm of this trial, there was a subset of patients that responded remarkably well to CAMS, which with 8 to 10 sessions versus DBT, which was 16 sessions over twice a week treatment. So a lot more dose of DBT. And the good news was that for a subsample, maybe 50% in the CAMS arm, they responded quite nicely to CAMS, but there was not a reduction in impulsivity and some of the other variables that we'd like to see. So what I would say is that DBT is the first line intervention for these kinds of chronic states, but does seem like a subset of individuals might respond well to CAMS as well. This is a sequential multiple assignment randomized trial, or SMART design. In this case, college students are randomized to CAMS versus treatment as usual. About half respond. Those that don't get additional randomization to more CAMS or DBT. What's important about this trial was treatment as usual was better than CAMS for patients that were highly dysregulated at baseline with multiple attempt histories and borderline features. Treatment as usual was better. And part of the thinking there was, from one of our reviewers, was that in CAMS, we're focused on getting rid of suicide, where in treatment as usual, they probably weren't as preoccupied with getting rid of suicide as you are in the CAMS condition, which means that maybe this hot potato warm blanket thing is in play in this study. We're now replicating this with a big trial. This is the campus trial, $11 million across 4 medical centers, or 4 university counseling centers. We're also doing additional research now in something called the Hope Institute, which is a clinic in Perrysburg, Ohio, that's now being stood up in Arizona, at Atlanta Children's Hospital, where all they do is outpatient work, primarily with CAMS, but also in a DBT skills group. Some get next day appointments. Some are seen intensively 4 times a week. They are stabilizing. This is Derek Lee, who's the founder of the Hope Institute. They're stabilizing the kids in 5.2 weeks and the adults in 6 weeks. So this is really an answer for what Donna was being asked about, which is, what if you can't get a bed? Or what if the patient could actually be effectively handled, even better, on an outpatient basis? They wouldn't have to be removed from work, or removed from school, or leave their family, but they could go to the Hope Institute, get stabilized until they get disposed to their outpatient care. So I'm really in the sort of the camp of trying to challenge that everybody belongs in the hospital kind of notion, knowing that a subset of people will always need to go to the hospital, but there's a large population of people with serious thoughts of suicide who can be effectively cared for on an outpatient basis. Here's my final slide, just to give a little sort of color to this discussion. This is a case of a woman named Kelly, we'll call her, out west in the Intermountain West, who is a 42-year-old female, very profoundly traumatic history, both of rape and sexual trauma, physical trauma, was diagnosed with borderline personality disorder, made her first attempt at age 17, twice married and divorced. She had additional children, a chronic history of clinical depression and borderline personality. She was engaged in CAMS for 42 sessions. We see our response mostly in 6 to 8 sessions, but 42 is a lot of CAMS. That's a big dose. And she gave her therapist this rather sweet card. Dear Jan, even though I was impossible, you never gave up on me. While it's been hard, I'm both excited and a little scared about resolving my suicidal risk after all these years. It's been decades. When we first started, I just reacted to everything that upset me without ever thinking. Now I think before I act, and I'm feeling much calmer overall. Finally, when I think about it, I feel like CAMS basically spoiled the milk I used to drink. Thanks again, Kelly. So if you kind of get the spirit of this, this is a way that this woman's been for a long, long time. 42 sessions of a very intensive, outpatient-oriented, suicide-focused framework really helped her ultimately resolve. But there's a little fear involved, a little sort of, can I be okay without this involved? But also the idea, if you want to be analytic about this, that, that this is the milk I used to drink. You could sort of go to town on that if you want. But what I'm saying is this was a comfort that's no longer the comfort that it once was. And from a therapeutic standpoint, I'm saying that's a big win for both the patient and this clinician. So that's what I've got. I wanted to give plenty of time for questions and answers. These are the various people that make my world go round. I'm a byproduct of Marsha Linehan's mentorship. These are the various people in the cohort that Marsha raised into the field to become experts in the field. A lot of people don't know this, but in the early 2000s, Marsha convened a series of meetings in Seattle where she had a number of us younger investigators come and bring some of our students to learn about grant funding and learn about randomized controlled trials and how to develop treatments. And now a number of us, including people in this picture here, Shireen Rizvi, Craig Bryant, Marjan Holloway, we're now leaders in the field. So Marja, has really made this incredible difference in our field. So I'm blessed with great collaborators and amazing lab, and that's what I got.
David, that is a wonderful presentation, and I'm so glad that you kind of wrap things up with that message of hope that you shared, because it's such an important reminder that this work that you do and the reason we have these educational workshops and so forth is all to add to that hope. I mean, this work makes a difference. So thank you for that. A lot of questions have come in. How do we reconcile individuals taking lethal doses of illicit substance and suicide? In other words, would we consider someone taking an obviously lethal dose of fentanyl a suicide?
Well, this is who depends who you talk to. During the pandemic, there was an a very, very significant increase in opioid overdoses. And a lot of the suicidologists were arguing, well, that's really those are hidden suicides, or people that are gambling with a very, very lethal drug of abuse and losing the gamble. So we don't know. I mean, there has for a long time been in the field of suicide prevention the idea of chronic suicide, or there's been a bunch of different names for it, but parasuicidal behavior. That people that I had a veteran at the VA hospital where I interned who was drinking a fifth of vodka, driving 100 miles an hour on the Beltway, and smoking 6 packs of cigarettes a day. Just incredibly high risk, abusive, self-harming behavior, but wasn't suicidal. So we can debate this. Suicidologists, believe me, do all the time. But the interface of high risk behavior, especially around substance abuse, is highly controversial or debatable. But we do think that while we saw a downturn in 2019, 2020 in the overall suicide rate, we steadily saw increases in ideation, increases in opioid overdoses, and now we're back up for the last 2 years, and the dip was short-lived.
One of our attendees asks, what is the percentage of chronically suicidal patients completing suicide, and any data on at what points in life?
That's a great question. I'm not sure. I would say I think I do know that for borderline personality disorder, this is either the leading cause or a leading cause of death. By definition, chronicity means that you've been this way for a while. And then we have the gender differences. So, probably according to that Mayo study, the chronicity really loads heavily on women. And in the general scheme of things, women are much healthier than men. They live longer. They have less severe acute psychopathology, less psychosis and schizophrenia. But they die much less often by suicide. Again, men are 79%, according to provisional data from the CDC of our deaths. So, by definition, a lot of chronic people live with suicide for a long time. I can just say as an aside, we have conducted a new line of research in my lab looking at people with lived experience. So these are people who have been suicidal, are suicidal, have made multiple attempts. And I had sort of pitched this idea for a post-suicidal life, because we can get people to not be suicidal remarkably quickly in CAMS. But a lot of them don't know how to live. And I say that, again, descriptively and not in a provocative way. The soldiers that we study, for example, in one clinical trial that we did, get that this is a new mission, and the mission is to not kill myself. So I got that, but how do I live? And I'm thinking of one soldier who had like a truck he was leasing and being deployed again, and 3 different kids by 2 different women, and a lot of chaos and trauma in his own history. And he really had no good sense of how to live. Long story short, the idea of a post-suicidal life that I thought was going to be so compelling, for some of the people we're talking to, it's like, that's not my jam. I'm good. I've got suicide in my back pocket. I'm doing well. I'm going to die by suicide, but I'm not acutely suicidal. It's just a part of me. So it's a different thing. And that's why I'm really trying to bring up a number of different foci to this, to kind of be empathic of it and not be pejorative or finger wagging about it. Because for people for whom this is a real thing, it's a way that they get by.
You mentioned the gender differences that have stood out to you in your research. Pretty fascinating all the way around. A viewer asked, do you have hypotheses regarding chronically suicidal female patients experiencing reduction in suicidality during hospitalization versus male patients sustained suicidality? I know you had a slide about that at one point.
Yeah, I don't want to offend anybody, and I don't want to be controversial. I think men actually understate their distress. And I think the women in our study were overstating their distress. To give yourself as high a rating as they did, and then 4 or 5 days later to be dropping down that quickly, I mean, it's a good unit, and the care there is very robust. But I think it speaks to a different kind of psychology, and I think in our culture, men tend to downplay things and internalize and be agentic, where women tend to be more relational. And it shows. It's why they live longer. It's why they do better. It's why they're probably better performers in treatment. As Dr. Burke pointed out, in the DBT trials, over dozens of trials, there are these big booming effective responses. They're predominantly among women. And Marianne Goodman did a DBT trial in the VA in the Bronx and got no signal at all, and because they were 82% men. So it does speak to maybe some of the differences that we might want to think about in terms of our suicide-focused treatments being gender-specific, and maybe how we can tailor treatments for different genders and different orientations and different kinds of populations.
You mentioned COVID. A viewer says, during COVID, my organization had to stop the side-by-side sitting of CAMS.
Yeah.
There has been some resistance returning to it. How integral is it to the treatment itself?
We'll know in about 2 years, because we had 4 clinical trials that were interrupted by COVID. What I can just say as a clinician and as a trainer and as a person watching dozens of videos from RCTs, we have 5 RCTs going on right now. I don't think it makes a big difference. I think it's a different kind of intimacy. And there are certainly benefits and there are certainly costs. There's a meta-analysis that came out 2 years ago showing that telehealth is as effective as face-to-face psychotherapy. Actually even a little bit better for certain kinds of cognitive behavioral treatments for depression. So I don't think the data shows that there's a loss, but there are preferences. So just as an anecdote, there was a case that I consulted on of a student in our campus trial, extraordinarily suicidal, where the clinician had only met with this patient online, and the patient had an aborted suicide attempt, and quite literally for the next appointment said, I'm going to drive to, it was a remote campus. I'm going to drive to your campus and meet with you face to face. And it was an incredible moment. You're here for me. Oh my God. It was the first time they had actually met face to face, quite literally. And it was different. It's different when you're telehealth and face to face. And that was their initial meeting of each other. So I'm very pro telehealth. I think it's a democratizer. Getting out services to rural and remote parts of our nation. You don't have to live in a city to get care. Is it perfect? No. I've seen patients, whispering into their laptop in their closet while their nosy mother is trying to listen in. Not good. That's not good. But if you can sort of accommodate that, if the hardware is there, the software is there, I'm a big fan.
Question regarding CAMS. Is it effective for BPD or NPD? And would you please speak to how it is implemented, if so?
BPD, bipolar disorder? Is that what we're asking? Is that where?
I would have guessed borderline personality disorder, but
It works with a subset. I would not say it's the first response treatment for borderline personality disorder. DBT by far. Adherent, as Michelle was saying, adherent. Four coordinated elements of DBT intensive is the way to go. If you don't have that, CAMS is certainly a good backup. CAMS is much easier to learn. It's much less labor intensive, and the effect is more rapid typically. And we've seen really nice effects of having borderline patients stabilized by CAMS and then graduate to DBT intensive. I'm not sure what the NPD.
Fair enough. We'll move on to one final question here. Is there any research on using CAMS within a jail or prison setting, and would modifications be needed?
Yeah. Oh, yeah. We were in the Georgia Juvenile Justice System. The children could not use a pen to write out their SSF, so we had to have the clinician do that for them. Telehealth now is being used as a way for clinicians to be perhaps a little bit less discomfort. In California, we did a lot of training. There were a lot of clinicians who really preferred like the hierarchical model of I'm the doctor and you're the patient. I know what's best for you, and sort of eschewed the idea of a collaborative approach. And then some that just loved it. I'll just end with this. There was a great case of a young PsyD who was determined to use CAMS and didn't get a lot of support for it. So she actually did it in the waiting area in the plexiglass. She's on the phone. She's got the SSF on the plexiglass. Great outcome case. We're going to write it up. We never did. But I mean, it's a great outcome case where highly unusual circumstances where the prisoner was quite responsive. So yeah, we've done it. We haven't done systematic research, but we certainly used it in those settings.
David, I wish we had more time. Alas, we do not. I want to thank you very much for your time today. What a great presentation.